The concepts of this chapter, of course, the priority concept is elimination. The interrelated concepts are fluid balance and electrolyte balance, and then acid-base balance. And that is an important role of the kidney. So you really need to pay attention to this, okay? This is a review here of the interstitial and extracellular fluid. Now, I know y'all remember this well from your anatomy and physiology, not. So I want you to listen to this and get that in your head again, because this is so important with the role of the kidney, what it does, and how it balances our fluid that we have in our body. So please listen to this, and you will be glad you did. The organs of the renal urinary system, and you can see here that the left kidney is a little bit higher than the right one, but they're very, 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 very close to the major arteries and veins within our system. So that's important because the kidneys are very vascular, and they require a certain amount of blood pressure to be perfused. So when a person's blood pressure drops, then we have to think about the kidney function. So that's something we'll discuss along the way, okay? So let's look at the structures of the kidney. The structures are identified here, and this is the workings of the kidney, so to speak. The main things that you're going to be concerned about is this right here, the nephron. There are 2 million nephrons in our kidneys, 1 million in each kidney. So we have a bunch. The renal pelvis is right here, and that is where it houses all of these vessels that are coming and going. The renal vein and the renal artery are here. And if you'll notice, there are renal arterioles all in the medulla of the kidney. Sorry. Here's the anatomy of the nephron. Now the nephron is the super duper important part, because this is the workings of the kidney right here. You have your Bowman's capsule, and that's that right there, and the glomerulus. Well, that glomerulus is what filters, and you can see it looks like a little sponge in there, and it filters the blood as it goes through. So you have this really long system of venules and the arteries that go through the kidney, and you have these loops and all these convoluted tubules and the ascending limb of the loop of Henle and the descending limb of the loop of Henle. All of this is so important, because this is where we get rid of what we don't need and keep what we do need. So this is one nephron. And remember, if you'll remember, I told you there are 1 million nephrons in each kidney, thereabouts. So each one of these nephrons have this anatomy here. And this is a juxtamedullary nephron. Now this thing is so important because it responds to blood pressure. It responds to sodium, potassium. It responds to when the body needs things. So this nephron, you better know what a nephron is and why it's so super duper important. And if we lose our nephrons, we lose the function of our kidneys. Now here's your juxtaglomerular complex. This little rascal sits right in this area, and it has the distal convoluted tubule, this one. It has the efferent arteriole. It has that Bowman's capsule, which houses what? It houses the glomerulus. The proximal convoluted tubule, and there's the glomerulus right there inside that Bowman's capsule, and the renin producing granular cells. Oh my gosh, that is super important. You better know what renin is. Afferent arteriole and the macula densa. So this is all very important parts of the kidney. This is the juxtaglomerular complex. Again, this is just anatomy that I'm talking to you about, a little review. But I just feel like you need to know this because this is what we're going to be talking about before when we're talking about changes in the kidney function. So now here's your renal tubules. They're deliberately, the Lord made them this way. This is how they are in our bodies. I had nothing to do with it. The image right here is what I want you to know. This is where the sodium and water reabsorption happens. And this is in the cortical part of the nephron. You see the sodium right here. These are your tubules that goes down, around, and different things happen in these areas here. You have the ascending, which means it's going up, where the sodium is more prominent. And you have the descending here, which is very permeable to water. So why do you need to know that? Well, because if we're giving diuretics, we need to know how to get the water out, don't we? So this is why it's so important that you know where things are happening in the renal tubules. Now let's talk a little bit about acid-base control. Your kidneys control the ion concentrations and acid-base balance of the blood. Whoa, what does that mean? It means that the kidney is a huge part of maintaining our acid base. The body's acid base balance is very, very tightly regulated, and it's regulated to keep the arterial blood between the pH between 7.38 and 7.42. The kidney bicarbonate buffering system maintains the optimal pH levels. Well, how does it do that? Well, it regulates the carbon dioxide concentration that will shift any acid-base imbalance. Well, how? How can it possibly do that? Well, it has the control of our sodium and can secrete or maintain our hydrogen ions and sodium bicarbonate. Biggest part is the bicarbonate. Now, if it needs to get rid of the hydrogen ions, it can, or it can secrete sodium bicarb. So this is how it's very, very, very powerful. And if you will notice, this is underlined and bolded, and that might mean something. And you might need to remember what the kidney does to maintain our acid-base balance. Commit that to memory, please. Now, we talked about renin a while ago, and I told you need to know about renin. Renin, what is renin? It's an enzyme. We've talked about enzymes before, haven't we? Well, this assists in the regulation of our blood pressure. Yay! It's formed and released when there is a decrease in blood flow, or if there's a decrease in volume, or if there's a decrease in the pressure of the renal arterioles, or when there's a decrease in the sodium ion concentration in the filtrate. And how is this detected? Remember what we talked about a little while ago? It's detected through the juxtaglomerular complex. So renin is a very, very important enzyme that's in your kidneys, and it is regulated through the juxtaglomerular complex. That's some kind of bolded there too, huh? So you might better remember that one too. Very important. And then we got our aldosterone. Well, all these blamed hormones. Yep, sorry about that. Aldosterone is important also in the regulation of sodium ion concentrations in the extracellular fluid. The extracellular fluid, remember, is blood plasma. So this is super important in blood pressure control. Very, very important. And if you have increased aldosterone, it will cause increased potassium secretion. Some of our medications that we give are have aldosterone or a derivative in them. So you have to know what it does. Increase in aldosterone causes increased potassium secretion. We all know how important potassium is. Aldosterone targets the cells in the distal convoluted tubule. This is a very important blood pressure hormone. Now, this next part is super important also. So these first few slides here are so important for you to know because it helps you to understand what happens when there's a problem in the kidney, that you can get some really big blood pressure changes. So here we go. The RAAS, this is the renin angiotensin aldosterone system, RAAS. So you will see this in lots of parts of things that we talk about with the kidney. You're going to see these terms. When the kidney receives a low blood pressure signal, or a low renal blood flow, or low serum sodium concentrations, this system is activated. These signals are sensed by the juxtaglomerular apparatus, which then secretes renin. When renin encounters angiotensin, it acts as an enzyme that promotes the conversion of angiotensin into angiotensin 1. Well, okay, that's kind of ringing a few bells, I hope. This angiotensin 1 is detected in the lungs. When it gets to the lungs, that angiotensin 1 encounters angiotensin converting enzyme. I hope that rings a bell. And is converted from angiotensin 1 to angiotensin 2. Now, angiotensin 2 has two main functions. One is to act as a potent vasoconstrictor. What happens when your vessels vasoconstrict? They get smaller. What happens to the blood flow through them? It goes faster. What happens to your blood pressure? It goes up, 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 up. So this results in increased blood pressure. And the second function is to stimulate the release of aldosterone, we just talked about that, from the adrenal glands, and antidiuretic hormone from the pituitary gland. Remember that antidiuretic hormone? In the adrenal glands, angiotensin II then triggers the release of that aldosterone by the adrenal cortex, and it will act on the kidney at the distal tubules, and it promotes the reabsorption of sodium and water into the blood. What does all that mean? What happens then? Well, this will increase the blood or the fluid volume, which will then increase the blood pressure. So you remember what we just said. When the kidneys receive a signal of low blood pressure or low renal blood flow or low serum sodium concentrations, all that's going to happen. And if you'll remember, we've just talked about this, angiotensin and angiotensin 1, angiotensin 2. What kind of drugs do we give to lower blood pressure? Ah, is that ringing a bell? ACE inhibitors? Yeah, angiotensin converting inhibitors. Do you see why you need to know this? Okay. Now here's another YouTube that I want you to watch, so please watch this. It will give you some added insight into what we're talking about. Now let's talk about what happens to the old kidneys when we age. Remember we talked about the cortex and the medulla, and then on your videos you saw that. Well, you get cortical tissue loss and the nephrons get smaller. The blood flow to the kidney declines, and you get a decrease in the glomerular filtration rate, which we will talk about in a little bit. But that's going to be another very important term that you're going to need to know. Very important, related to kidney function. The glomerular filtration rate. As we get older, that puppy gets older, and you have a decrease in the GFR. And people have to get up at night to go pee because they have a decreased bladder capacity. And people should not drink before they go to bed because they'll have to get up. Older people, any people will have to do that. In women, sadly, we have weakened urinary sphincters and shortened urethra in our plumbing. And we also have a tendency as we get older to retain urine. Okay, here's another little YouTube you can watch for added entertainment. And another one. Assessment of the kidneys. What do you got to do after you're doing we've been over all this stuff. Now what are we going to look for? Why does it matter that we know what's going on with the person? Why do we need to know anything? We know that history is a huge part of our knowledge of our patients, don't we? Well, let's talk about that. What do you need to know? You need to know their demographic information. That helps you to know where they live. Do they have access to certain things like bathrooms and food, and do they have ways to get their medicines? You want to know what their medical history is. What do they eat? And you also want to know family history and genetic risk. Now, there's a lot of things that happens in the kidney that are genetically are problems genetically and are passed from the mother and father to the children. And we'll talk about those later, but I do want you to be aware that there's some definite genetic risk factors. Also, what their current health problems are. Do they have high blood pressure? Do they have low blood pressure? Do they are they on any medications that will control the blood pressure? Are they on diuretics? You want to know all of this stuff. So the history is huge, especially for people who have problems. And so be sure you get a good, clean history from these people because you need to know. Then you're going to look at them. You're going to look at their general appearance. Do they look like they take care of themselves? Is their skin, do they have scratches? Do they have any rashes or anything that might make you think they have uh, strep infection, which you will notice later that that's going to be a huge thing. And you're also going to look at their abdomen. And when you do your palpation, and y'all know how to do a palpation, you know how to assess the abdomen. Well, when you can't feel the kidneys unless there's a growth or something. Um, there are some diseases that will make uh, nodules and cysts in the kidney, and you can see those a lot of times. You want to know about the ureters. Do they have any, have they had stones? Are they having any problems with their bladder? Do they have any itching? Do they have any burning? And the urethra, especially in a man, you want to see if there's any discharge or anything from the urethra. And from women, sometimes they will get these infections, candida, and that can be that's yeast infections, can be pretty horrendous. If you've ever had one, you know what I'm talking about. And psychosocial, what is their psychosocial situation? Now, let's go on after we've assessed our patient. Now let's talk about the glomerular filtration rate. Remember that I said this is a biggie, and you better know this because this will be part of your knowledge that you're going to want to know from now on. It will follow you all through your career. One of the things that you're going to look at on the lab work is the GFR. There's certain labs that you must know related to the kidney. And I have this underlined, bolded, every which way I can. This is way, way important. So memorize this slide and understand this slide. Now let me help you understand it, okay? When blood passes from that afferent arteriole into the glomerulus, remember the glomerulus is where filtration takes place. This is where water, electrolytes, and other particles, including creatinine, urea, nitrogen, and glucose, are filtered across this glomerular membrane into Bowman's capsule to form what is called glomerular filtrate. As the filtrate enters the proximal convoluted tubule, then it becomes what's known as tubular filtrate. Are you with me so far? We're going through the glomerulus, and water, electrolytes, and other particles, and you need to know these other particles are going to be important too. Glucose, creatinine, and urea nitrogen. They are filtered across that glomerular membrane into Bowman's capsule, and this forms glomerular filtrate. As the filtrate enters the proximal convoluted tubule, then it becomes what is known as tubular filtrate. It just changes its name as it goes down. Now, please understand that if all of our filtrate that we have in our body is excreted as urine, we'd die. We'd get dehydrated so fast it wouldn't even be funny. So, it doesn't happen that way. That's why you got all them tubules and whatnot that go down through there. This is so important. We only actually excrete about 1 to 3 liters of urine each day. It's the ability of the kidneys to self-regulate that renal blood pressure and renal blood flow that keeps the GFR constant. It is controlled by selectively constricting and dilating the afferent and efferent arterioles. When the afferent arteriole is constricted, or if the efferent arteriole is dilated, then pressure in the glomerular capillaries falls and filtration will decrease. When the afferent arteriole is dilated or the efferent arteriole is constricted, just the opposite of each other, then the pressure in the glomerular capillaries rises and filtration increases. This is how the kidney maintains a constant GFR, even when the systemic blood pressure changes. So it follows that. It's very, very, very sensitive to the blood pressure. Now, I've tried to put this on the slide here, what I've just said in a condensed form, but I hope you understand that. And if you don't, please let me know, because this is so important. If the blood pressure drops below 70, then that compensation doesn't happen. The GFR will stop. So a very low blood pressure requires a blood pressure above 70. The normal kidney function is a GFR of about 100, but it's called an estimated GFR. They may be shown as over 60 or over 90. As we grow older, that's going to drop. As kidney function deteriorates, that's going to drop. So this is why this is so important. Now let's talk about some more hormones. I pray that you got that GFR down, because these hormones play into the GFR. Specific prostaglandins are hormones, and these are produced in the kidney, and it's these two right here, which I do not expect you to have to know, but there you go. These help regulate that glomerular filtration and the kidney vascular resistance and renin production. If you have an increase in the renal blood flow and the glomerular filtration rate is associated with decreased or actual circulating volume, this will cause, the prostaglandin will cause increased tubular flow and secretion of potassium. So prostaglandin production is important. Now let's talk about another enzyme. There's several enzymes that we have to know about, and or not enzymes, hormones that are produced in the kidney. Erythropoietin is a hormone that is produced and released in response to decreased oxygen tension in the renal blood supply. What in the heck does that mean? Well, it's stimulated it stimulates red blood cell production. So decreased oxygen tension in the renal blood supply. Hello, it decreased oxygen in the blood. Erythropoietin is produced and it goes to the red blood cell and it says, hey, we need some more blood. We need some more RBCs. Wake up. Get with it. So, why would this be important? Well, obviously, if we bleed, somebody needs to take action and give us some more red blood cells, right? Well, that's what this is for. So, the erythropoietin, that hormone will notice if there's a decrease in the oxygen supply in the blood, and it detects it in the renal blood flow. What's going to happen if we lose our kidneys? Good thought, huh? When the kidney tissue is destroyed or it's not functioning, then the erythropoietin production decreases and the person will become anemic. How about that? So erythropoietin is super duper duper important, and that's why you see a lot of anemia in renal patients. So let's look then at what we're going to look at. What kind of blood tests, what kind of things are we going to look at? Well, let me tell you that it is very important that we know some lab results that we're going to need to do. Blood tests, urine tests, and some imaging assessments that we're going to need to know. They'll probably do a KUB just to look at the kidneys, especially if you have kidney stones. I've had a bunch, and they're not fun. And every time I go, they'll do a KUB to see if they see any more stones. They may do a CT, an MRI, ultrasound. I've had all of these. I've had a renal scan. I've never had a renal arteriogram. So let's talk about the urine first, because obviously we're going to have to know about the urine. So what do we need to know about the urine? The urine will identify the presence of glucose, ketones, proteins, red and white blood cells, sediment, and bacteria. So you're going to look at the color, and you're going to notice if there's a smell. Sometimes it's very malodorous. The specific gravity tells you about the dilution, how much solute is in the urine, the osmolality, and the pH. Now, if they feel like they may have a urinary tract infection, they will do a urine culture and sensitivity, and that requires a midstream clean catch, and it will detect infection that's in the urine. And really all urine specimens that you get should be a midstream. If it's a voided urine, it should be a midstream clean catch urine specimen. Now, if they have to have a 24-hour urine procedure, they would discard that first void and then record that time when they discarded it as the start time. And then they save each void until the 24-hour period ends, and that will include the very last void. Since the first void is discarded, all urine in a 24-hour period is actually not saved. So when you're collecting a 24-hour urine specimen from a client with an indwelling catheter, you have to put that on ice, and you have to empty it into a collection bottle, which is also kept on ice. So that's how that works. Serum creatinine. Wow. This is another one, and you'll notice there's some bolding on here. This is a measurement of the end product of muscle and protein metabolism. it is filtered by the kidneys and excreted in the urine. So, our muscle mass and the metabolism are generally constant. So, if it stays the same all the time, then it should be the same value all the time. That means that serum creatinine level is a very, very, very good indicator of kidney function. No common pathologic condition other than renal disease results in an increase in serum creatinine level. No common pathological condition other than renal disease results in an increase in serum creatinine level. And it will not increase until at least 50% of the renal function is lost. So any elevation of serum creatinine value is important. And you watch that. Normal serum creatinine levels will vary with age, gender, and body muscle mass. The normal serum creatinine value is slightly higher in adult men than in adult women. Why? Because men have a larger muscle mass than women do. But there are some exceptions. Muscle mass and the amount of creatinine produced diminish with age. Because of the decreased rates of creatinine clearance, the serum creatinine level remains relatively constant in older adults unless renal disease is present. So what lab value are you going to be watching? That's what I thought. Serum creatinine. Now let's talk about the urine creatinine clearance. Well, this is going to give you a calculation of your glomerular filtration rate, and it's also one of the best indicators of overall kidney function. And how does this work? Well, I tell you right here, the amount of creatinine is cleared from the blood is measured in the total volume of urine excreted in a defined period, and it's generally 24 hours, but it can be shorter. The calculation requires a comparison with the blood creatinine level, which is drawn at the very same time that at the collection ends. Normal creatinine clearance is 90 to 139 milliliters per minute for adult males and 80 to 125 milliliters a minute for females. And I have been known to ask questions on the test regarding that. Yeah, I have. Okay, let's talk about the BUN, the blood urea nitrogen. Some people call this bun, and I can't because it makes me think of a hamburger bun. I just can't call it bun. But it's blood urea nitrogen. This measures nitrogen fraction of urea, which is the chief end product of protein metabolism. It's a measurement of the end product of muscle and protein. That's not true. Sorry, I got my slide mixed up. This is formed by the liver from ammonia, and it's excreted by the kidney. It reflects protein intake, the liver's ability to metabolize, and the renal excretory ability. Now, if you have a high BUN, it could be because your blood is, or you're dehydrated. Your blood is concentrated. So your BUN could go up when a person is it has a profound dehydration. Or if they've been bleeding a lot. Remember, this is a product of protein metabolism. So it could be up for different reasons. So it's not really a good indication of the BUN except for one thing. The normal BUN and creatinine ratio is 10 to 1. So if that changes, if it goes different, if the ratio is different, then it might be a condition of the renal system. So if you see that, we always do a BUN and creatinine, but remember that BUN can be related to bleeding, liver failure, all kinds of things. But the creatinine ratio, to the BUN and creatinine ratio, is normally 10 to 1. So you may see that calculated. The normal is 5 to 20. Let's talk about some invasive interventions that they might do to check the kidney. And why do I want you to know about these? Well, I want you to know because some of these can cause the urine to be pink tinged, and that's normal. Sometimes they'll go into the the uterer, and they'll do a ureteroscopy and laser for people who say have a kidney stone. And they'll go in there and they'll laser it and they'll go up through the ureter. Well, that's going to cause the urine to be pink tinged after the procedure. And a cystoscopy would also cause pink tinged urine. So when you're looking at these assessments, these imaging assessments that we are going to talk about here, the KUB, and I go over that on the next slide. All of these we're going to go over on the next slide. The KUB is a picture of structures and organs in the belly, in the abdomen. The contrast is not needed here. And there's something you're going to need to know about contrast. A CT can be with or without contrast, but sometimes it's with contrast dye. Now, contrast dye can cause kidney damage. An arteriography does use contrast dye. It shows you more about the blood vessels than the CT does, but it uses contrast dye, and that can damage the kidney. Ultrasound, this does not use contrast dye. It doesn't use radiation. It doesn't use anything, just looking at the kidneys. The only caveat here is that you should do this before they do any barium testing of the abdomen. An MRI, we all know what an MRI is, and it can give about the same information as a CT scan, and it will use a different kind of contrast, and this can cause problems too, but it doesn't really affect the kidney so much as it does the brain, and there is some fibrosis that can occur in the nephrons. So any of these are useful, but some of them can cause, actually, that if the contrast dye is used, it can cause damage to the kidney. And there is something that you can give the patient if they already have kidney disease and require the test to be done. We'll talk about that later. Okay, they can also have a cystoscopy and a cystourethropy. and they can have that cystography and a cystourethropy, which is the blood vessels, or they can have some retrograde procedures like going up through the bladder to see if there's retrograde urine, urodynamic studies, and kidney biopsy. And a kidney biopsy is usually done to diagnose. Now let's talk about those contrast agents. This is what I was talking about a while ago. Contrast agents, when you're doing a diagnostic study for renal disease or renal problems, you have to protect the renal function. And if they're getting this nephrotoxic contrast agent, it can decrease the renal perfusion for up to 20 hours following that contrast administration. Whoa. You already got problems, so this is not a good thing for them to have or to give them without some sort of treatment. The caution for patients on metformin is very important also, because that medication, and a lot of diabetics are on metformin, this will cause increased damage to the kidneys. The dye will cause increased damage to the kidneys of patients who are on metformin. Now what do we do then? If they really need it, what are we going to do? So we're going to give them Mucomist. And this is acetylated L-cysteine. It is an antioxidant, and it's a scavenger of free oxygen radicals. So it will enhance the vasodilator properties of nitric oxide. It has a very, very, very disagreeable odor, and people don't like to take it. And they give it in grape juice, but it still stinks. It smells like rotten eggs, okay? So, you have to hydrate our patients. We have to hydrate them. We have to make sure they have a good amount of fluid volume if they're not on fluid restriction. If they are restricted, then we have to give them this Mucosil, which is what I just told you. It's given in doses of 600 milligrams twice a day, starting the day before the procedure. They get a total of 4 doses. And then they will give them some sodium bicarb to create an alkaline environment, which will diminish that contrast media potential for nephrotoxicity. Yeah, it's that important. So you may see this given, and you should be aware of why you're giving it and how crucial it is that the patients take this. Now, if they are on metformin, which is also called glucophage, you do not give it for 48 hours after contrast is given. And this is to decrease the chance of developing lactic acidosis. Contrast medium causes temporary damage to the kidneys, and because the kidneys remove metformin, the contrast medium can greatly increase the level of metformin in the blood. So, you have to wait 2 days, assuming their kidney function is normal. If renal function is normal at 48 hours, then you can restart the metformin. Very, very important, and that's your job as a nurse to keep these patients safe, and you better know that, because sometimes you're the only thing between them and acute kidney failure or kidney injury. There's no scientific justification for withholding metformin for 48 hours before the administration of the contrast medium. It is recommended in the package insert, but there's no scientific justification. And you can think about that as somebody comes in and they have an urgent need and they took their metformin this morning and they've got to have this the contrast dye, then we do all of these things to minimize the danger, but we can't get that, you can't wait. So you don't give it for 48 hours after the dye infusion. It's the most important thing. So IV fluids are needed because in anybody, if they have contrast dye, they will give them IV fluids because the dye that's used in a procedure with contrast has an osmotic effect and can cause dehydration and potential kidney failure. So, the client may be hypovolemic. You have to monitor the blood pressure and administer IV as a priority described treatment after the procedure in order to flush the dye out of the system. And I do believe that is underlined. It is. Okay. Question 1. Which client does the nurse identify as the most likely to experience renal compromise assessed by decreased urine production? A 12-year history of diabetes, a white blood cell count of 13,000, recent history of an MI, a blood pressure of 92/48 millimeters of mercury for 12 hours. Think about what we talked about earlier, okay? And yes, I'm going to give you the answer on the next slide with a rationale. Yes, but look at that. What does our blood pressure need to be to perfuse the kidney really well? And this is for 12 hours. The answer is D. The ability of the kidneys to self-regulate renal blood pressure and renal blood flow keeps the glomerular filtration rate, again, very important, constant. A blood pressure of 92/48 millimeters of mercury is a mean arterial pressure of 62 millimeters of mercury. It's your MAP. You got to have at least 60, right? So this means they may have a compromise because this is very low. Some people, I know, and you know, run a low blood pressure. But the kidney has a difficult time regulating the GFR with a mean arterial blood pressure less than 65 millimeters of mercury. Watch your labs. Question 2. My dryer just went off. Question 2. A client with kidney failure whose pulse oximeter is reading 96% reports dyspnea. The nurse reassesses that client and sees that they're visibly distressed with a respiration rate of 32 breaths per minute. What is the appropriate nursing intervention? Y'all better know this. You're going to call the respiratory therapist? Or you're going to call the doctor? You're going to give them a little oxygen? You're going to elevate the head of the bed to 90 degrees? What are you going to do? What is your appropriate nursing intervention? Think about it a minute. I am going to give them a little oxygen because When they're anemic, they can't produce that erythropoietin. A high oxygen saturation in an anemic client who is showing signs of respiratory distress may still be hypoxic. Clients who have a decreased hemoglobin, again, watch your labs, could have a high percentage of hemoglobin saturated with oxygen, but because they have a decreased hemoglobin level, not enough oxygen is provided. Administering oxygen is necessary. How about that? That makes you think, and that is called critical thinking. That is called clinical judgment, and that is what you must provide. Okay, one more question here. A client with a history of kidney disease is admitted with acute shoulder pain. Which order will a nurse discuss with the prescribing healthcare provider? Your client has a history of kidney disease and he has acute shoulder pain. So which order are you going to discuss with the prescribing healthcare provider? DH 0.125 milligrams by mouth daily. Metoprolol 50 milligrams by mouth twice daily. Cultures for a temperature of over 38.5 degrees centigrade. Or ibuprofen 800 milligrams by mouth every 4 hours. Okay, they came in, they have a history of kidney disease, and they came in with acute shoulder pain. What do you usually give somebody for acute shoulder pain? What would the doctor probably order? But he has a history of kidney disease. Some of these orders are just arbitrary orders. It may be what the patient's on at home. But what are you going to question? Can kidney patients take ibuprofen? We've heard this before in other lectures, and the answer is no. I want you to understand that ibuprofen and any non-inflammatory NSAIDs, any of those non-inflammatory inflammatory medications will harm the kidneys. So high doses, and this is definitely a high dose, every 4 hours. Dang, that is a lot of ibuprofen, 800 milligrams. So the answer is D. High dose or long-term use of non-steroidal anti-inflammatory drugs, or the NSAIDs, can seriously reduce kidney function. So the nurse will discuss this with the prescribing healthcare provider. Again, you're going to look at the labs because they're going to ask you what the labs are. They're going to say, what's his creatinine? What's going on? What's his GFR? They're going to ask you some things and want to know what kind of renal problems they may have. Patients sometimes forget to tell people in the ER that they have these problems, or they're woolly and they don't remember not telling it, or the family doesn't remember, whatever. So this would be something that you would question personally. I would question on just about anybody. That's a lot of anti-inflammatory drugs. Ibuprofen 800 milligrams. It used to be that they gave it, but not every 4 hours. That is a lot. Okay, this ends this this chapter, and I have gone over sort of a high-level overview of what I want you to know going into the next chapter, which will be care of the patients with urinary problems, so that you can think about what we've had here and sort of figure out why they're having the problems that they're having. So that's the end of this particular chapter, chapter 60. See you in the next chapter.